Well, I can't tell you what an honor it is to be with you today virtually to speak about the role of regional analgesia beyond acute pain management. And as mentioned, I'm Ed Mariano, and I'm a professor at Stanford University. I don't have any financial disclosures, but I want to first start by talking a little bit about Professor Carli. And I think that we've already heard so many of his many accolades, hundreds of publications, and impact on the field of perioperative medicine, within our community as anesthesiologists, as well as from our surgical colleagues and all of the healthcare professionals that work around this perioperative space and take care of patients who have surgery. I had the great pleasure of meeting Professor Carli more than a decade ago, when we were actually both speakers at a meeting in Italy in which we were talking about the acute to chronic pain transition and the ways that we as clinicians and scientists really work together to try to advance patient care. I also had the quite difficult role of having to follow Professor Carli, as you can see here, in one of the first panels in which we actually spoke together. And I can tell you firsthand, as someone who stood in the audience and listened and asked questions, that he is an incredible pioneer in our field, as well as in surgery. It has made such a huge difference for patients. So it gives me great honor to help hopefully do this lectureship justice in honor of Professor Carli. So to speak a bit about the role of regional anesthesia and analgesia, I thought I would take the lens of perspective, starting first with the patient, of course, and then looking at the healthcare system, and then, of course, what's important to society at large, and how do we, as anesthesiologists and pain physicians, really work together to try to impact issues that matter in terms of global patient care. The reason why I always start with the patient, of course, is because everything we do in clinical innovation, in science, in education, ultimately comes back to improving patient care. At least that's the goal. And so when I think about, in my mind, when I'm thinking, coming up with questions and ideas and speaking with colleagues from either locally or around the world about what we can do to make things better, I always have this mental picture, which actually is an actual picture, this photo that I'm sharing with you today on my slide. It's a photo that I took of the front of the Veterans Affairs Palo Alto healthcare system the day that I interviewed for my job as chief of anesthesiology. And the man in the front, who did not know that I was taking this photo, and thankfully is anonymous because he's turned his back to me and is walking towards the hospital, happened to get captured in that photo. But I use this photo a lot in lectures because I do think about, what if this patient was walking towards the hospital? He has a cane in his right hand, and maybe he's going to our preoperative clinic. Let's assume that his surgery is coming up in the next 6 to 12 weeks, and he's going to have a knee replacement. How do I know that the care that he's going to receive, how do I know when I'm counseling him about the surgery he's about to have, that what he's going to receive on the day of surgery is what we expect? How do we know that we're able to provide that consistency in high quality care delivery, so that way we know for any patient on any given day, any time of the day, any day of the week, regardless of which teams are assigned to handle his care, how do we know that he's going to get the high quality care that we think that every patient should get for this operation? I think this is really an important piece, at least in terms of my approach to patients, when I think about how we not just prepare patients for surgery, but also how we integrate regional anesthesia into that care. The way that I have thought about regional anesthesia, and one of the most important aspects of regional anesthesia that I find appealing, at least in clinical practice, as an anesthesiologist and as a perioperative physician, is that it really is personalized in literally every sense of the word. I mean, I think that when I consider what regional anesthesia potentially does, which is anesthetize a specific part of the body, we are literally making anesthesia as personal or as individualized as the surgical procedure itself. We can be very targeted. And so in concept, even from that very broad conceptual basis, regional anesthesia is really the most personalized form of pain therapy that we can offer patients in the immediate surgical episode. Now, I don't think that we're at the point where we can make truly individualized care plans for each patient. We just don't know enough about each individual patient. And I'll talk about this at the very end of my talk. But I do think that we can use regional anesthesia techniques, not just as intraoperative anesthetics, but really as analgesic techniques in terms of perioperative pain medicine, to offer patients different levels of care based on what we anticipate they may need. And I think that we are at that stage now. Now, I've been very inspired by the work of Professor Carli, and I've read many, many articles and listened to many talks that he has delivered. And it's really made me think a lot about what we measure and what we focus on in terms of priorities for patients. This is one article that Professor Carli has written, and just commenting on how we define outcomes after major orthopedic surgery. And it's important because there are outcomes that we can measure, and there are outcomes that really matter, and they're not always the same. I think that we have a difficult time assessing the outcomes that patients really consider high priority, because those patient-oriented outcomes and those patient preferences are not always captured in electronic records. In fact, they're rarely captured in electronic records. So we have a hard time knowing what they want. And because of that, I think that we have a difficult time planning interventions and making decisions about care, because we tend to choose the outcomes that we think are important to us. They're important to clinicians, they're important to health systems. But as you can imagine, in major orthopedic surgery in particular, there's always a balance of goals. We want to provide great pain relief, but we also have to facilitate rehabilitation. We have to increase mobility. We have to make sure that patients are on the right track for enhanced recovery. And because of that, pain is not the only outcome. And that's the reason why we need to look at other outcomes. And this is where Professor Carli has really been on the forefront in trying to show us beyond pain management, that there are many other outcomes like disability and return to activities of daily living and quality of life and quality of recovery that we really need to think about besides just pain. Now, when I think about the impact of peripheral nerve blocks or regional anesthesia on a large scale, looking at population-based studies, then oftentimes our friend and colleague, Stavros Mimsudis, who's based at the Hospital for Special Surgery and Cornell Medical School and School of Public Health. Many of the works that he and his research team have done have really looked at these large databases to try to look for observations that may be important signals for us on a population level of why certain aspects of care may be different if we choose certain interventions. And this particular study is an old one. This goes back a decade. And I think it's powerful in the sense that we can see these associations of peripheral nerve blocks with good things, with lower complication rates, with decreased length of stay, with lower rates of transfusion, both of which signal lower cost utilization on the healthcare side. But at the same time, I think when you look at the utilization of regional anesthesia, and at least speaking specifically in the United States, looking at this particular database set using Premier, we can see that the penetrance of peripheral nerve block, at least in joint replacement, is extremely low. And this may be lower than other health systems, and I'll acknowledge that there are limitations in the use of administrative data, but even if we assume a higher estimate, which we've seen in other studies of maybe 27%, if you average those out, then it's about maybe 1 in 5 patients in the United States has a block for a major lower extremity joint replacement. And which means that most patients, maybe 80% of patients, don't have access to this type of pain control modality that has potentially associated benefits to it. And I think that's really concerning. And so when I think about it from a population level, going from the patient specifically to all patients, I think that the benefits of regional anesthesia and peripheral nerve blocks, if we believe that they exist, really have no potential to improve outcomes on a large scale until they are available to all patients. And this is not where we are right now. And I think the way that we think about this issue, and I've thought about this a great deal, just because when we get together at meetings nationally, internationally, much like the meetings in which I met Professor Carli, and then we talk about these issues. We may be true believers in the clinical benefits of the practices and the research that we've invested time in. But that doesn't mean that they are finding their way to the bedside. And unfortunately, the time for translation from new evidence that even becomes a clinical practice guidelines, to changing clinical practice is estimated to take about 17 years. And Professor Wenberg, this is actually a Dartmouth professor that Dr. Brian Seitz, who's the editor-in-chief of Regional Anesthesia and Pain Medicine, that he got me reading some of his work, is really interesting. And he's given this a name. He gives it the name unwarranted variation. And unwarranted variation is a variation in clinical practice that you cannot explain based on patient illness, patient preference, or medical science. And I think we see this every single day in healthcare all around the world. There are reasons why you should individualize care. So there is a such thing as warranted variation. And I would argue that warranted variation is personalized medicine. That's when you influence your decisions based on patient either comorbidities, patient status, patient preference, or new evidence. When you read new evidence and believe it and try to incorporate in your practice, then that's warranted variation. That's when you change what you normally do for a good reason. But if you see variation in clinical practice from one physician to another, without any of these factors incorporated, then that's unwarranted variation. It really should be something we try to eliminate, because that, going back to that the man who's walking towards our VA hospital, who may be having surgery in the next 6 to 12 months, that's taking away our ability to predict what type of care he's going to receive when he finally shows up for his surgery. So I think we've all faced this type of a quote, whether it's "we've always done it this way" or "that's not how we do it here." I think that's another version that we've all heard in healthcare. I think that we have to start to move away from that and really start to think about how we improve care in a way that is based on those three main factors, either patient illness, patient preference, or medical science. And we need to find a way to make our care much more consistent, so that way we all believe the same evidence and we all incorporate new evidence into clinical practice. So that's a good segue into talking about healthcare systems. And I think that as we go and try to broaden our ability to improve patient outcomes, when we're taking care of a patient in front of us, we can ensure that that patient gets the highest quality care, because that's 0 degrees of separation. You're delivering that care. But it's more important, I think, for us to take those best practices and make them much more available on a large scale. And this is really where we need to go in terms of improving care throughout health systems, not just your specific health system, but imagine national health systems in which you can start to broaden the high quality care that patients receive throughout your population. And I think that we as anesthesiologists in particular have really focused on this immediate intraoperative or perioperative episode. And it's very, very finite in the way that we define the beginning and the end. It's immediately before surgery with the pre-op preparation for surgery, and then it's this intraoperative or perioperative protocols. And this is where we've really focused on enhanced recovery. I think these are things that I think we have been leaders in, and I think that we've made important strides to improve patient care this way. But that time frame is fairly limited, and I'll talk a little bit about that. I think we know that regional anesthesia is one part. It's one part of pain management around the time of surgery. The local anesthetic administration delivered by anesthesiologists in the form of regional anesthesia is even only one way that we administer local anesthetics. We can also give them intravenously. We can give them by surgeon infiltration. There are lots of ways to give local anesthesia. And then, of course, there are other classes of pain management modalities. Some are non-pharmacologic. And then of the pharmacologic modalities, we have opioids. And then, of course, we have non-opioids. And the truth is, many of these classes of medications are not routinely used, even when they're not contraindicated. The ones that tend to have very few side effects and have benefit, especially the non-opioid agents and non-pharmacologic interventions, really should be routine for most patients, unless there are specific contraindications. And then there are certain classes of drugs like gabapentinoids and NMDA antagonists that may be beneficial for certain patients, but maybe not for all patients. And I think that we have this interest, I think, in trying to incorporate what we do best into patient care. And I think that's why many of us within the regional anesthesia community, and I'll admit to being a zealot when it comes to regional anesthesia, that's why we get so excited about regional anesthesia. I love these graphics from Professor Carli's article about regional anesthesia and enhanced recovery, because I think it shows, how regional anesthesia can be an important aspect of the way that we provide enhanced recovery protocols for patients, but it's not all of enhanced recovery. It's one part. So you can see how the overlapping Venn diagram of regional anesthesia techniques, using them when they're best indicated to actually provide selective pain control and avoid side effects from general anesthesia. You can see advantages of advanced surgical techniques, and we've seen a great deal of innovation in surgery to try to provide enhanced recovery, including minimally invasive approaches. And then, of course, there are other aspects of perioperative care that cannot go unnoticed. These are primary issues in terms of patient education and preparation, physiotherapy, clinical nutrition, which I know Professor Carli has been a world leader in perioperative nutrition. All of these things contribute together to try to improve patient outcomes. And I love this overlapping word cloud that shows that really collaboration is the best cure. And you can see all of the different elements of perioperative care, from anesthesiologists, physiotherapists, surgeons, and we see geriatricians, other physicians, family medicine, through primary care, psychologists, nurses, nutritionists, and pharmacists. And I think that this is really a beautiful diagram, and I recommend that everyone who's seeing this, hopefully you can share this image and hopefully disseminate it broadly. We've also seen from Professor Carli's work that what we do in terms of regional anesthesia in the context of enhanced recovery and fast-track surgery is really one intervention, one set of interventions that really help the overall progress of patients who recover from surgery. It's, as I mentioned before, it is not complete. You have to do more than just regional anesthesia, but there are benefits. We know that regional anesthesia, by blocking afferent neurons, I think that we have the ability to affect vascular perfusion, especially in patients who depend on that for wound healing. And we also know that there's better oxygenation of tissue. I think that pain relief helps to facilitate early activity. And we know that we can affect the stress response by blunting the body's detection of noxious stimuli. I think these are all important aspects of the way that we provide good care. I think it's also very important that we look at the way that if you do a side-by-side analysis, and I know this is a very busy table from Professor Carli's article, but what I did here is I tried to oversimplify. What you see in the red box are all the positive aspects of regional anesthesia and analgesia when it comes to fast-track surgery and enhanced recovery. And then on the right side, you see that's not boxed are all of either the no difference or negative impacts of regional anesthesia and analgesia. And you'll see that there are very few. So even just looking at this table, you see there are more positives than negatives when it comes to incorporating regional anesthesia and analgesia into enhanced recovery pathways. And I think we have more options available to us. I think in the early days of enhanced recovery after surgery, we talked primarily about thoracic epidurals, but now with the rise of plain blocks in regional anesthesia, and we've seen many, many, many new blocks. This is just a snapshot of just looking at PubMed of articles that had plain block in the title from the early 2000s to last year. And you can see that for the last few years, we've seen hundreds of articles per year with plain block in the title. So needless to say, there are many options at our disposal when it comes to providing regional anesthesia. Now, a big question, and maybe perhaps for many of us in the regional anesthesia community, is, do we have enough blocks yet? And I would argue that we do. And this is not to stifle innovation, but I do think that we need to take what we have right now and just make sure that more patients are getting it. And I think this is really it's a reference back to the article I showed you earlier, where amongst a million patients in the United States having primary joint replacement, only 12.5% actually got blocks. So I think that there's a lot of work to do on our part to really advocate for patients and educate patients and caregivers, as well as our colleagues, and not just our surgical colleagues, but all of the clinicians involved in perioperative care, that we do have these powerful tools at our disposal that can help in terms of patient recovery. And I think it's important when we think about regional anesthesia in a health system perspective, that we really try to demonstrate value. Now, regional anesthesia, good pain control that leads to early recovery, that is highly visible. And we need to be able to show this as high quality care. But we also need to show how we can reduce or contain costs. Value is very simply the equation of quality over cost. And I think if we're able to do that, we can have those conversations with our health system administrators. This is just one example of showing data. So this study was performed at Stanford through our Department of Surgery. And the way to interpret this is that we see adjusted odds on the y-axis. When patients have poorly controlled acute pain, so patients on the right side of the graph show high acute pain, they have a higher adjusted odds of coming back to the hospital within 30 days for emergency services and readmissions related to pain. This is not surprising to any of us who've taken care of these patients in the perioperative and postoperative periods. We know that these patients who have poorly controlled acute pain are likely to have higher utilization later. But this is really where we, as perioperative physicians, as anesthesiologists, can advocate for the value of the services we provide through regional anesthesia and analgesia. This is our opportunity to make a difference and to convince our health system administrators that we can help not just improve quality of care, but also reduce costs of care. So let's move on to society. And I think this is really important because, while we may think that what we do is so important within the medical community, and let's say that we've been able to convince our health system executives, that they need to invest in the processes and clinical operations that we want to offer so that way we can improve and enhance the recovery after surgery for all patients. That how do we make sure that those the lay people, our communities, our legislators, how do we know that they are paying attention to the work that we're doing? And I think this really has to hit home for every person, not just those people who are involved in healthcare. This is really where we need to make a stronger argument. Like, why is this a public health problem? I'm going to argue that chronic pain, or the transition of acute to chronic pain, is a public health problem. And these are data that we've seen from Professor Carli, and all of us in acute pain know of these data. But there are certain types of surgeries that we know have a high incidence of transition from acute to chronic pain. We know about thoracotomy and bypass surgery, and as well as amputation. We know that you can have chronic pain as frequently as 1 in 2, or 50%. But I think what's also important and what's really impactful for our communities is the fact that when this becomes chronic pain, it can be disabling. So a subset of those patients who go on to develop chronic pain after acute pain from major surgery, they will be disabled. And so that has huge ramifications in terms of societal productivity and economics. In the United States, the estimate of the cost of chronic pain is about $600 billion a year. And this, I think, is it's almost an unfathomable number because it's so large. Half of that cost is thought to be directly attributable to healthcare. The other half of that cost is attributable to lost productivity. Think about it. If patients have chronic pain and they're not able to work and they're disabled, then they're not productive in society and they're not contributing to the economy. In addition, think about when those patients have chronic pain and they can't take care of themselves, that means that there's a ripple effect in which the caregivers, the family members of those patients, end up having to lose productivity in order to provide that type of support and home-based care for a lot of these patients that cannot work anymore. So there are huge potential implications if we are able to make a difference in the transition of acute to chronic pain. Talking about amputation, and this is something that that we have had many discussions about within our research group locally as well as nationally and internationally, and one that my good friend Dr. Juan Francisco Asenio and I have talked about and asked me to speak about this particular question today. As I mentioned, amputation as being one of the most common surgeries that transitions from acute to chronic pain, and now over a decade ago, locally, when I was still working in the same place as my friend Brian Ilfeld. We had this initial pilot study to evaluate the potential benefits of continuous peripheral nerve blocks in patients with existing phantom limb pain. So patients who've already had an amputation. So using what we consider an acute pain intervention like continuous nerve block to try to make an impact on chronic pain, and that already exists. Interestingly, we had 3 initial participants, and you can see in the graph below that they were all scheduled to have an initial either randomization to saline or local anesthetic, and then were given the option for crossover to the opposite arm. All 3 happened to actually get saline. We lost one to follow up after the initial period, but then the other 2 crossed over to local anesthetic, and you can see the very dramatic drop off after the crossover, in which for the next several weeks, up until week 12, those 2 participants actually had almost minimal phantom limb pain. And this really got us thinking very hard about, could we reset this pain cycle by interrupting this transmission of signal from the phantom limb back to the central nervous system. And so we got to work with Brian Ilfeld as our PI for a multi-center study and lead to see if we could make a difference. And the results of this multi-center randomized clinical trial that was supported by the Department of Defense was published in Pain just a couple of years ago. And what we saw within this particular study was we saw some short-term benefits, and by short-term, we used as our primary outcome time threshold 4 weeks. And this is somewhat complicated, and I'll mention some of the nuances of the study because I think they're very relevant. Is that while we had a similar type of model in which we randomized patients and then gave them the optional crossover, they were given the option of crossover after 4 weeks. And what made this somewhat complicated is our funder definitely emphasized the need to provide this crossover option. Because of that, it was really difficult to know whether these benefits extended long-term, because after the crossover, as you can imagine, since these were patients with existing phantom limb pain, a good number who crossed over, it was very difficult to know whether that initial treatment for the first week really made a huge difference in the long term, because there was a lot of overlap in our populations after those who received saline initially also got exposed to the active drug. But what you can see here, at least within 4 weeks, is you can see some benefits in phantom limb pain, as well as some residual limb pain in the subjects who received active drug for a week versus saline for a week. And this is very enlightening for us, because I think that this idea that we may be able to have some benefit, while very difficult to track on a long-term basis at 6 and 12 months, was still, I think, meaningful, in that perhaps there was a signal here that we could offer a relatively simple intervention that we do every day for our surgical patients to aid in chronic pain that amputees already suffer from. We looked at this a couple of other times in secondary analyses, and what we tried to do was really look much more closely because, as you can tell from our initial study, because the primary outcome is really set at 28 days, we focused on that in the reporting. So in these 2 secondary analyses, one of them, we looked specifically at the week-to-week changes for these patients from baseline to 28 days in phantom limb pain and also residual limb pain. And you can see that the initial drop really occurs within the first day. What's also interesting, and something that we comment on in this paper, is that in order to be eligible for this particular study in the randomization, all participants had an initial local anesthetic block with lidocaine. And then if they responded to that, then they had their catheters placed and they were randomized to saline or local anesthetic. So you can see here, even in the blue lines, those participants that had placebo, they actually also had a drop within the first day. And so we comment on this in the paper as one of the challenges, I think, in trying to understand how that circuitry works in terms of perpetuating phantom limb pain. Could there actually be some benefit to even that very, very short interruption of pain signal transmission from a single short-acting local anesthetic block. And that may be true, and you can see that from the numbers. In addition, this most recent one, secondary analysis that we published in Regional Anesthesia and Pain Medicine, looked not just at averages and medians, which we often report in our clinical studies, but what would be meaningful, clinically meaningful from a patient care perspective, from the patient's point of view. And I think this is actually a very important question, because how do we know that what we do matters to patients? And so, we went through our data again to try to figure out, how many patients actually got clinically relevant improvement. And so we defined that, here, looking at a change in reported numeric rating scale of more than 1.5. And so when you look at that, it's actually really interesting. So they're looking at phantom limb pain in particular. You can see the reduction, the comparison of clinically relevant improvement was more than double for patients who received local anesthetic versus the placebo infusion. And I think this is important because it does provide a different perspective of what is important to patients, which I mentioned before, and something that we really have an opportunity to explore much, much further in the interventions that we provide for patients with chronic pain. I think that it's exciting to think that, well, maybe the blocks that we have, that may have longer term implications, but I do think that there are some limitations to our knowledge. And I think that one aspect that I think I try to really consider, or one important context I try to consider, is the fact that regional anesthesia, as I mentioned, is really only one part of good pain management. And when we worked on this project with 13 other societies a couple of years ago to develop principles of good pain management for all patients having surgery, you can see that it's not just regional anesthesia. Multimodal analgesia was considered one of our principles, but there are so many other aspects of good pain management that all of these surgical societies, as well as our American College of Obstetrics and Gynecology, American Medical Association, American Hospital Association also agreed with, which is, you can see that the importance of good preoperative preparation, which I know Professor Carli has really been a pioneer in this, access to a pain specialist, for patients who, regardless of where you are and where you're getting care, you really need to have that, that specific pain medicine expertise available, especially when you don't respond as expected from the pain of surgery. I think we need to learn more about how we provide our blocks and how long blocks should last. I think that we have the opportunity to study this even further. Professor Lavandome from Belgium has done some important work in this. And I think that, we tend to fight about, how long a block lasts, from 1 day to 2 days, based on whether you use adjuvants or liposome bupivacaine or continuous catheters. But as you can see from the graph, patients who have a knee replacement, even if you don't have chronic pain at 3 months, you may have moderate to severe pain for almost a week. And that's normal. And there are some patients who will actually have neuropathic chronic pain, and they'll declare themselves around day 5, when many of our patients in the United States are at home. We also know that patients will differ from each other in the way that they respond to pain. And these 5 squiggly lines represent 5 different pain trajectories that we know exist. And these are data from University of Florida, in which they looked at patients who had multiple different types of surgeries. And while we assume that every patient will start out high and then decrease over a few days, like this dashed line that you see here on the graph, there are 4 other trajectories there that patients may exhibit. And not all of our patients are going to be that slopey dashed line. And that's important. And we cannot predict who they are yet. And I think this is where we really have a lot of work to do. I think our opportunities to innovate really lie in this subacute period in order to intervene before patients become chronic pain patients. Like Professor Carli and the work that he's done in patients who are preparing for surgery, as well as postoperative enhanced recovery and rehab, I think we need to look for those opportunities where we can interject ourselves into that care paradigm, so we can hopefully provide patients with good pain management in that subacute period and avoid the transition to chronic pain. I think we have the opportunity to keep patients on their rehabilitation pathway and continue on a trajectory of recovery that allows them to achieve all of the preoperative goals that they set for themselves. I think we have a lot of work to do. I think we have models that we have to explore, like transitional pain services, as well as other modalities for regional analgesia, like cryoanalgesia and neuromodulation, that are different than the way that we provide nerve blocks, but I think offer some real opportunity to try to provide selective pain control that lasts longer than our local anesthetics in select patients who may actually have some benefit. And so one day, I hope, we'll have this concept. While this is written as a research paradigm, I think it's a clinical practice paradigm where one day maybe we'll be able to identify those patients based on their genotypes or phenotypes or a combination of both, that tell us what type of pain trajectory they'll have after surgery. And we can tailor our care around pain management for surgery in a way that is very individualized. So that way every patient is getting personalized medicine in a way that I think that they deserve. And hopefully that's when we'll be able to really make a dent in the transition to chronic pain. And so with that, I'll leave you. We've talked about the patient perspectives from health systems, system-based role, as well as how we make impact and really show the value of our services to society. And I thank you again for the honor of being the Franco Carli lecturer. And I hope that I've done this justice for really a giant in our specialty. Thank you very much.